government offices. It's a consistent attribute of these programs that nobody in the program says, this may be what you need, but it's not part of my job or not part of this agency's job to help you get it. Now that is a very difficult stance for a large program operating out of a large human service system to take. But I think that's one of the big challenges we have, to figure out how you can do that and reach a great many more people than these smaller programs that are easier to mold in this fashion. One program that illustrates this sort of coherent, comprehensive approach is a nurse home visiting program that was done in Elmira, New York. They worked with high-risk mothers, starting when the mother was pregnant and going on until the baby was 2. They provided not just health services and information, but parent education, family support, employment counseling, housing and nutrition assistance. With that wide array of services, they were able to reduce the rates of low birth weight babies. They were able to reduce the rates of child abuse and of hospitalization for the children. A second closely related attribute of these effective programs is active collaboration across professional and bureaucratic boundaries. You have to put disparate services together. You have to add the missing pieces to enable the frontline worker to mobilize the resources that can really respond to a family's untidy collection of real-world troubles. In these successful programs, the frontline workers end up with unusual job descriptions because they make their job descriptions in response to the needs they encounter rather than in response to the bureaucracies within which they work. I think that the experience that Eugene Lang had with his I Have a Dream program is very interesting in this respect. You all know about the fact that he promised a group of 60 Harlem sixth graders money for their college educations if they would stick it out through high school. What's a little less well known about that program is that he figured out very early on that promise of distant money was not going to be enough. And he hired a community organizer by the name of Johnny Rivera. Mr. Rivera worked with these 60 kids and their families for 6 years, full-time. And when I talked to him, it was in the 6th year, he said, you just can't imagine the extent of these kids' unmet needs. He said he helped families fund health care and social services and housing. When necessary, he says he went into the homes to rouse the kids out of bed and get them to school. He went with parents to accompany the student to the principal's office when the student had been suspended for fighting. It's this collection of intensive supports that both Mr. Lang and Mr. Rivera feel was at least as important in accounting for the success of that program as the promise of tuition payments. A third attribute of successful programs is that they deal with the child as part of the family and the family as part of a neighborhood and community. Most of these programs respond to the needs of 2 generations at once. They have deep roots in the community. In successful child health programs, the clinician sees beyond the child on the examining table, and if that child is suffering from diarrhea and he's in there for the 3rd time, the clinician, be it nurse practitioner or physician, asks himself or herself what is going on with that family, what does that family need? Does that family need the help of a public health nurse, a social worker? I visited a health clinic in Mississippi that actually delivers clean water to families who have no other access to clean water as a response to seeing a lot of preventable diarrhea. A fourth attribute of successful programs is that staff have the time and the training and the skills necessary to build relationships of trust and respect with children and families. Staff say that they work in a setting that allows them to develop meaningful one-to-one relationships and that they can provide services respectfully, ungrudgingly, and collaboratively. Now, as one thinks about this list of characteristics, it's obvious that the attributes of successful programs are in a very profound way out of sync with the real worlds of bureaucracies and politics. The major elements of success are at odds with the dominant ways that most large institutions and systems are funded and the way they're expected to assure accountability and quality and equity. Comprehensiveness is at odds with categorical funding. Flexibility and frontline worker discretion are at odds with traditional ways of setting standards and of assuring accountability. Intensiveness and individualization are hard to reconcile with traditional approaches to assuring equity. I think that we have to come to grips with this mismatch. Otherwise, successful models are going to continue to flourish briefly in splendid isolation and then to disappear. Governor Kaine of New Jersey said after the Governor's Education Summit in Charlottesville last fall that there isn't a problem in education that hasn't been solved somewhere in this country. The same is true in health and mental health and social services. What stands between the isolated model program and getting effective services to all who most need them are the changes that are needed in systems to accommodate what works. And I think that finding ways to overcome those barriers, the barriers to the spread of successful model programs, is even more difficult than the development of successful models in the first place. And I believe that that is the challenge that's ahead of us now. We have to craft strategies to make systems more hospitable to the kind of programs that have proven effective. To do that, I have 4 suggestions. First, I think we have to develop funding mechanisms that go beyond individual programs and isolated services. One approach would be to experiment with the idea of geographical neighborhood targeting of funds. If coherence is essential to effectiveness, the process of putting services together at the local level can't continue to be so onerous that only St. Francis of Assisi, who is also a Machiavelli and also a CPA, can succeed. We have to make it a little bit easier, and I think that can be done at the federal level, where I doubt it's going to be done very soon. It could be done at the state level, and maybe, most hopefully, it could be done at the city level. It would be possible to earmark a certain proportion of current public expenditures, including funds that support maternal and child health, compensatory education, preschools, family support, child care, mental health, and social services. Through the use of automatic waivers and regulatory changes, these funds could go into a single pot, a sort of a flexible superfund that would support coherent, intensive services in areas of greatest poverty and social dislocation. The target population would be defined geographically in order to minimize barriers of access and to take into account the powerful neighborhood-level influences, both positive and negative, that affect child and family well-being. An initiative that aims at modifying public funding practices in this way could be modest in scale without being trivial, because it would target the populations at greatest risk and would tackle some of the major systemic barriers to the improvement of services. Second, we have to recognize that disadvantaged populations often have distinctive and greater needs that are not going to be met if one only concentrates on expanding access to a routine set of services that are adequate for the middle class population. Let me take an example. Prenatal care. The staples of middle class prenatal care, routine lab tests, regular monitoring of blood pressure and fetal growth, are not enough if the patient is a teenager who is pregnant and depressed and frightened, not eating properly, maybe drinking, maybe taking drugs, maybe doesn't have a permanent home. She requires a great deal more than conventional obstetrical medicine if she's going to have a healthy baby and be prepared to care for that child. Another example in daycare. The content and quality of care is most critical for the children who are growing up in persistent poverty. Their odds of school success will depend on the program's staff-child ratios being high enough, the group size being small enough. They'll depend on the program's ability to link up with health and social services and nutrition. It'll depend on the programs being able to focus on the children's developmental needs and to work successfully with parents. The children who don't learn at home, when I cry, I will be picked up, who don't learn at home the preschool basics of cause and effect, of now and later, of trust and reciprocity, these are the children who aren't going to bring to school the social capital that's required to become well educated. And these are the children for whom carefully designed, enriched interventions in the early years, whether they come in a program labeled Head Start or daycare or preschool education, those interventions, if they're high-quality interventions, can make the difference between a high or a slim chance of school success. Third, I believe it's becoming increasingly clear that efforts to obtain new funds, especially public funds, and to use old funds under new and more flexible rules will succeed in today's climate only if they're coupled with clear commitments that effectiveness will ultimately be demonstrated in improved outcomes. It's better to know that all children are immunized and learning to read than how many doctor visits have occurred and how many lesson plans have been filed. Lastly, when it comes to systems change, an ever larger public has to become convinced that quick, cheap fixes are not going to solve the complex problems that we're most concerned about. No matter how eager politicians may be for simple models that need only to be cloned, it's the attributes, the subtle attributes of successful programs that are crucial, and they can't be mechanically replicated. They have to take different forms in different communities, and they have to be owned and shaped by the community if they're going to become sturdy foundations to build on. The public, as well as experts, have to come to understand that local communities have to own and shape local programs. Most of the work has to be done locally, but also that it won't succeed if it's done only locally. Without state and federal incentives to encourage collaboration, local efforts are almost impossible to sustain. And of course, the other piece that also can't be left only to local communities is the economic context in which all these interventions must operate. Jobs that pay a living wage are crucial. It's very hard to persuade youngsters who are growing up in poverty to play by the rules if playing by the rules means losing the game. 1 in 4 children live in two-parent families. 1 in 4 poor children live in two-parent families with a full-time, year-round worker who doesn't earn enough to keep the family over the poverty line. So we have to combine efforts to improve services with efforts to assure the availability of decent jobs at decent pay. Now, I want to conclude by talking